So thanks a lot, Savas, for the kind introduction, and thanks a lot for the invitation. It is an honor to be here. I will be talking about treatment of the acute aortic syndrome. And first of all, we have to distinguish what is the acute aortic syndrome. It comprises of three different clinical entities: aortic dissection, meaning a tear in the intima of the aortic wall, resulting in formation of a true and a false lumen; penetrating aortic ulcers with a rupture of a pre-existing plaque on the aortic wall, or intramural hematomas between the medial and adventitial layers of the aortic wall. These are the respective CT images of these three pathologies. Although it is not that common as the acute coronary syndrome, the acute aortic syndrome is a catastrophic medical condition, and it should be regarded in the differential diagnosis of patients presenting with acute chest pain. We are talking about 10 patients for 100,000 residents per year, and the majority of these cases is aortic dissections, penetrating aortic ulcers, and intramural hematomas account for about 15% of the acute aortic syndrome. So when we're talking about acute dissections, we first distinguish anatomically between type A and type B dissections. And this is a very straightforward classification. Type A dissections are the ones where the intimal tear is situated in the ascending aorta. They account for about 60% of dissections. And type B, the ones where the proximal intimal tear is situated in the descending aorta distally from the left subclavian artery. So these are two examples. In the first case, a type A dissection with an intimal tear from the ascending aorta up to the aorto-iliac bifurcation. And in the second case, a type B dissection with the intimal tear situated behind the left subclavian artery and up to the renal visceral segment. The clinical symptoms vary. As I said, the most common symptom is severe ripping, piercing, interscapulary pain or chest pain, and it should be considered when a young patient presents with acute chest pain in the emergency room. And then we have a variety of symptoms depending on the localization of the entry tear and depending on which vessels are being affected by the dissection. So in the case of type A dissection, we have a multitude of possible clinical problems with cardiac tamponade, aortic valve insufficiency, stroke, peripheral malperfusion, or even rupture. And we have a very high mortality rate of about 50% in the first 2 days, with this perioperative mortality being affected clearly by the peripheral malperfusion. So in this case, we have these scores. We have the same patient, same age, same anatomic criteria. If this patient has no malperfusion, then we're talking about a preoperative risk of about 17%. If this patient presents with peripheral or visceral malperfusion, then the risk is higher at about 31%. And if this patient also has stroke symptomatology, then we're talking about a perioperative risk of about 40%. So what we do in type A dissection, we first try to lower blood pressure and heart rate, administer analgesia, and the patient has to be referred to a cardiovascular center with an interdisciplinary team, an aortic team comprising of heart and vascular surgeons. And in the meantime, we have recognized that the approach to this type A problematic has to be interdisciplinary because we have a multitude of clinical manifestations. In this case, for example, we see a type A dissection where the patient has a true lumen collapse in the right carotid artery due to the dissection. We were called on for this case because the patient had stroke symptomatology, and you see here in the ultrasound examination that the true lumen of the carotid artery is almost completely compromised by the false lumen. This is an ultrasound examination that we did on table. So in this case, we have a simultaneous approach, meaning that the cardiac surgeons do the sternotomy and we expose the right carotid artery. In the meantime, we fixate the intimal tear and the intima with a conduit, with a prosthetic graft that we use to achieve perfusion cerebrally during the extracorporeal circulation. And then we extend this bypass proximally, this conduit, as an ascendo-carotidal bypass to finish the reconstruction after the ascending reconstruction has taken place. Or in this case, another approach with in cases of true lumen collapse in the descending aorta, for example, simultaneous catheterization of the true lumen while the cardiac surgeons are opening the sternum. We are doing catheterization transfemorally. We position a wire, and then after the ascending reconstruction has taken place, we position a stent graft right at the level of the left subclavian artery in the open aortic arch in order to achieve exclusion of the distal portion of the dissection and open up the true lumen. Another case here, after ascending repair, where we see in the TE that the true lumen is still collapsing with every cardiac circle. So in this case, ascending repair and a combination of covered and uncovered stents up to the level of the aortobiliac bifurcation to expand and remodel the true lumen and address the malperfusion. In the case of type B dissection, the indication to treat is a bit more tricky. Up to a few years ago, these dissections were divided or classified as complicated and uncomplicated. And this classification was quite strict, meaning that the patients that had periaortic hematoma, rupture, or malperfusion were considered to be complicated. The patients that only presented with chest pain were uncomplicated. And in this sense, these uncomplicated patients were treated primarily conservatively. In the meantime, we know that there is a gray zone of high-risk patients, depending on clinical and morphologic criteria, that have a higher risk for midterm complications. What are these complications? Most of the patients with type B dissections of the descending aorta do survive the acute event. The problem is that most of these patients, or a high percentage of these patients, will develop long-term complications, meaning dissection extension, chronic pain, or aneurysm formation, which is a very challenging pathology to treat. So the options that we have is, first of all, the best medical treatment with analgesia, with antihypertensive medication. The patient is administered to the ICU unit, is controlled a couple of times with CTAs. And if the dissection is stable, then we proceed to administer long-term antihypertensive therapy to inhibit aortic dilation. The second option is to treat this acute event and exclude the primary entry tear in the descending aorta with an endograft in order to prevent rupture, to expand the true lumen, to correct malperfusion, and last but not least, to prevent aneurysmatic degeneration in the midterm. And currently, the treatment algorithm that we're using is somewhat more complex than this black and white differentiation between complicated and uncomplicated. Complicated patients with malperfusion or rupture are immediately treated with endografting. Patients that have clinical criteria for complications, meaning pleural effusion, progression of the dissection, recurrent pain, or refractory hypertension, are mostly treated in the subacute phase, 2 weeks approximately after the acute event. And patients that are uncomplicated clinically but do have morphologic criteria that speak for late dilation, meaning that, for example, the false lumen is very large or the entry tear is very large, then these patients are also treated subacutely with endografting. A couple of examples. For example, in this case, a large entry tear with pleural effusion that has been treated with 2 thoracic stent grafts, or this case, a very challenging patient with a rupture in the right hemithorax with 3 dissection membranes, a chronic aneurysm. These kind of patients would be considered inoperable. A couple of years ago, we did manage to save this patient, to contain the rupture with a combination of stent grafts in the true and false lumen, and proceeded a couple of days later to complete the reconstruction with a completely customized stent graft in the renovisceral segment. So this is what happens when an acute dissection degenerates in the midterm, and that's the solution that we propose at this moment. We have the option to fully customize endografts with fenestrations and side arms, side branches, which may continue to perfuse the renovisceral vessels while in the meantime excluding the thoracoabdominal aneurysm. This is the result when we implant these stents that are specifically made for each different patient anatomy, are patient-specific in the end. And we have published our results. It was the largest series worldwide with this kind of patients with chronic dissection aneurysms, where we saw that we have a good technical success rate and a high rate of thrombosis in the midterm of the false lumen. So in order to conclude, acute aortic syndrome is a challenging pathology. It requires prompt diagnosis and treatment. We have a combination of open and endovascular techniques at our disposal at the moment, and we have to use both of these techniques tailored to specific patient anatomies and tailored to the symptoms of the patient, to the clinical presentation, and to the vessels that are indeed affected by the dissection. And for me, this kind of pathology is a very good example of how more than one disciplines, more than one surgical fields, in this case, heart and vascular surgery, can work together in order to address this type of problems, which are to many the final frontier, especially in the aortic arch of cardiovascular surgery. Thank you very much.